This is our first round of resident seminars. Today I'm going to be talking about adrenal tumors. I picked this topic because for this hospital, this type of tumor basically can affect any of our specialties here, whether that's surgery, oncology, internal medicine, ECC, and anesthesia. So these do really take a whole team sometimes to get these patients in and out of the hospital, and they certainly come with their intricacies. So brief outline, we're going to talk about the gross anatomy and then switch over to microanatomy and physiology very briefly, and briefly go over some hormone review as well. There's a lot of nuances with diagnosing these tumors and trying to get as much information as we can before we go in surgically. The perioperative care of these patients is complicated. So we'll talk about that, and then surgical approaches and prognoses. So in terms of anatomy, these are paired, very small retroperitoneal glands. They're anywhere from 0.5 centimeter to about 1.5 centimeters. The left is a little bit more caudal than the right. They are both closely adhered to the adventitia of either the aorta or the caudal vena cava, as well as the overlying dorsal musculature, so the psoas muscles. They are composed of two major distinct zones. That's the cortex and the medulla. We'll talk about those in a second. They have a very rich blood supply, and the blood supply plays into their ability to do their jobs effectively. And so the glands have about 20 to 30 branches of arterial blood supply coming from the phrenico-abdominal, renal, and cranial abdominal arteries. The blood flows through the glands and into venous sinuses, and then quickly out the phrenico-abdominal vein, which allows adrenal products to be dumped into venous circulation very quickly. In terms of microanatomy, the cortex is split into 3 sections. So going from the outside in, zona glomerulosa, which creates mineral corticoids, the fasciculata, which makes the majority of the glucocorticoids as well as androgens, and then zona reticularis, which also creates glucocorticoids and androgens. The medulla produces catecholamines, and so that's from left to right on the screen. In terms of glucocorticoid function, glucocorticoids essentially regulate most functions and metabolism in the body. So stimulates hepatic gluconeogenesis, lipolysis, protein breakdown, as well as increases GFR and gastric acid secretion. It does inhibit protein synthesis, wound healing, the inflammatory response. It has a negative feedback cycle with the hypothalamus to prevent more of this hormone from being produced, being cortisol. I'll skip over all that other stuff because we're already behind. Mineral corticoids, the main mineral corticoid that we talk about in the body is aldosterone. So it stimulates water, sodium, and chloride reabsorption at the renal tubules, as well as potassium dumping. And it can lead to peripheral vasoconstriction and increase of overall body fluid volume. In terms of catecholamines, catecholamines also play a huge role in our body metabolism, as well as a crisis or fight or flight response. The adrenal medulla has direct sympathetic innervation and does react very quickly to sympathetic stimuli. In terms of catecholamines that are produced in the dog, the majority that is released is epinephrine, so about 60%, and then 40% norepinephrine. That is different in cats and in humans. Cats and humans tend to produce higher amounts of epinephrine in comparison to norepinephrine. These both have effects at alpha and beta adrenergic receptor actions. I could get up here and basically give an entire seminar about that. Very interesting, but it essentially affects all organ systems across the body. So Given that these are tiny paired glands, they're deep in the abdomen and they have a huge amount of function, how do we figure out if there's a tumor? So that's a great question. We have this term incidentaloma that has come about because in both human medicine and in vet medicine, adrenal tumors rather are incidentally found. And so Cook et al. In 2014 published a paper looking at, as a retrospective study looking at dogs undergoing abdominal ultrasound for reasons not related to a suspected adrenal mass. And they found that 4% of dogs that they scanned ended up having an adrenal mass. That was the chances of them having a mass was correlated with increasing age, so about 12 years of age and increasing body weight. In 2016, a similar study came out from Baum et al. Only instead of ultrasound, it was looking at CT. And so they found that 9.3% of dogs undergoing abdominal CT or even thoracic CT ended up having incidental adrenal tumors. They also found that increasing age was associated with an increased chance of finding these tumors. If we were screening for other neoplasia with those CT scans, that was also interestingly associated with an increased chance of an adrenal tumor. In human medicine, they've done post-mortem studies, and basically the older you are, the higher the chance you have of having an incidental adrenal tumor. Now, in humans, about 70% of incidental adrenal tumors are benign adenomas, which is different in comparison to animals. But basically, if you're a young adult, you have a low chance. If you're about 50 years old, it's about a 3% chance. And then once you hit 70, around a 15% chance that you're going to have an incidental adrenal mass, which is a pretty interesting spike. We'll move on. So there are several different types of tumors here that we can see. There's benign, there's certainly malignant, and then depending on which part of the adrenal gland the abnormal tissue is arising from, that can determine what type of cancer we get. So I'd say the majority of these tumors are primary, and about 70 to 80% are adrenocortical tumors. Of the studies I read, there are definitely varying amounts of adenoma versus adenocarcinoma. All of the studies I read seem to have a significantly higher amount of adenocarcinoma mentioned rather than adenoma. I think that may be a sampling bias because we have tumors that may be acting more aggressively or may potentially have metastasized, or we're more concerned that they're functional rather than a benign adenoma that we find and we say, hey, we're going to, consider leaving that. The currently accepted consensus is that we have about equal occurrence of adenocarcinoma and adenoma. About 16 to 22% of primary adrenal tumors could also be neuroendocrine in nature, so pheochromocytomas. With adrenal tumors, we can have them bilateral or unilateral. We can have multiple different types of masses in the same adrenal gland, or one type in one gland and then a completely different in the contralateral side. A 2005 retrospective study showed that I think this was higher than a lot of the other studies I was looking at, but they said that they found that 20% of their adrenal lesions were metastatic. Most other studies were saying lower than that. So how do we get to a diagnosis? So if you have, roughly 4 to 10% of dogs undergoing more advanced, more sensitive abdominal imaging like CT or ultrasound that we're finding these masses on, what do we do with that? So the first step is to actually confirm it. So a large amount of the utility of an ultrasound is based on the person administering the ultrasound. And so in our case, we have board certified internal medicine specialists who are doing it. versus someone who took, not to hate on it, but went and took a 3-day ultrasound class and is assuming that they can find it. And so we can either go and repeat the ultrasound, or a more sensitive method to pick these up would be bumping to a contrast abdominal CT. You can pick these up certainly with MRI. That, what would doc say? That's like using a sledgehammer to kill a gnat. So is that close to it? Close. So the advantage of going to CT when we're trying to work these tumors up is that contrast CT can be very, very helpful in terms of determining how invasive these tumors are, because invasiveness is going to tell us, it's not going to diagnose anything for us, but it's going to push us one way versus the other in terms of how malignant is this and what type of tumor is it potentially. So you can see it's 95% accurate for determining location of the tumor, 100% positive predictive value, and a 90% negative predictive value. So historically, it has been somewhat difficult to determine adenocarcinoma versus pheochromocytoma. A 2022 study just came out in JVIM that looked at, instead of using a 2-point scale for CT grading, they looked at 7 different points and 7 different factors, and they did get some promising results with that. It's a really complicated study. I'm not going to say I understood all of it, but things like tumor margins, and then whether or not they highlighted on like arterial versus venous phase, things like that. So step 1 with this is we want to confirm that there actually is a mass there. And then step 2, we need to determine, most importantly, if it's functional or inactive. And then second to that, malignant versus benign. It would be prudent to, and pretty much all the papers I read about this said, we just need to consider these malignant until proven otherwise. So pop quiz. How do surgeons determine if an adrenal mass is functional versus non-functional? So this is multiple choice. So A, thorough physical exam, imaging modalities, blood work, extensive literature reviews. Show of hands. No one. Flip a coin. Maybe. Call internal medicine. It's the right answer. So medicine's bailing us out again. So in terms of functional tumors, we'll talk briefly about cortisol secreting tumors. Any excessive cortisol production in the body over normal would be considered hyperadrenocorticism. Now, 80 to 85% of dogs with excess cortisol, that's going to be a pituitary dependent Cushing's disease, or a pituitary dependent process. 15 to 20% of those dogs are adrenal dependent. And so with these dogs, we may actually see clinical signs that are consistent with Cushing's disease, rather than this being an incidental finding and us starting to work it up. So we can use a low-dose DEX suppression test or an ACTH stim test. But if, I learned in school that if you had no suppression, that was consistent with an ADH, but it turns out 40% of pituitary dependent hyperadrenocorticism cases also fail to suppress. You can draw an ACTH level, and an adrenal dependent process is likely going to have low endogenous ACTH, which makes sense. We'll just keep moving. In terms of pheochromocytomas, these tumors are a little bit more dicey in terms of diagnosis and clinical signs, because these dogs may very well have significant amounts of time where they're completely normal and we don't have any signs at all. But the most common clinical signs noted in both dogs and cats would be sporadic weakness or collapse episodes. So you will likely see tachycardia, tachypnea, hypertension, arrhythmias, and sustained hypertension is a hallmark of this disease process. But even so, we can have these patients in hospital and have them be normotensive if they're not having catecholamine release at the time. So if we are concerned about these, we do recommend cardio workup with ECG echocardiogram. We can see possible left ventricular hypertrophy with these cases. I'm guessing that's probably due to an increased afterload. Imaging usually will look similar to a cortisol secreting tumor, only these are much more likely to have vascular invasion. These tumors tend to be more locally invasive than adenocarcinoma, but both can certainly be metastatic or locally invasive. So there are several metabolites that are catecholamine breakdown products that have been studied in humans and in dogs and cats too. Specifically, looking at the urine creatinine to norepinephrine ratio. They've looked at this in plasma as well. A couple of studies have shown that urine tends to be a little bit more sensitive and for picking up these products. Even all of that being said, it is not uncommon to not pick these products up in these tests. You can do a serum inhibin amount. So with Cushing's, this will be elevated. With a pheochromocytoma, it won't be detectable at all. There was some mention of clonidine or phentolamine suppression tests that you can do to test these. These tumors have been associated with concurrent other neoplastic process. So certainly something to look out for. In terms of perioperative management, these patients are notoriously difficult. So with a cortisol secreting tumor, one of the main historic problems is venous thromboembolism. I'd always heard this. I never understood the pathophys behind it, but essentially we think that excess cortisol increases the amount of procoagulant factors in the blood, and it also increases the fibrinolytic inhibitors. So we are recommending that we're pre-treating these patients with 3 to 4 weeks of trilostane to try to decrease the amount of excess cortisol. There has been a lot of discussion also historically because of the risk of thromboembolism. There's been talk of, do we anticoagulate these patients or not? I know when my dad was trained in human surgery back in the 70s and 80s, all adrenal patients were getting heparinized. That is not something I've seen translate over to the vet world. There have certainly been lots and lots of successful cases where people have heparinized these patients, but there's no major prospective controlled study in vet medicine looking at the effectiveness of using an anticoagulant therapy ahead of time with these patients. So with pheochromocytomas, the huge risks that we worry about are your massive blood pressure fluctuations, arrhythmias, as well as hemorrhage, and that has to do with basically the invasiveness of these tumors when we're going to take them out. The current recommendation is 2 to 3 weeks of a pre-op alpha blocker, so phenoxybenzamine is usually what we go to. In terms of surgical approaches, the most common surgical approach used for these is a ventral midline laparotomy. We have great exposure of both sides. We can see the cava very well. We can look for potential metastasis. You do have slightly more poor exposure to the dorsal retroperitoneum. And so this can be combined with a pericostal incision if you're having difficulty getting to the dorsal aspect of these tumors. A flank approach is sort of similar. And so with this, we'll make a pericostal incision and then start with a grid style dissection going through the abdominal wall muscles, just like you would with a grid gastropexy. It does provide excellent exposure to the dorsal abdomen. These are cases that we want to know that it's unilateral, the mass is not invasive, and it's going to be a more straightforward case. If there's any kind of tumor thrombus or a large size of a tumor, then this is probably not the way to go. On the right side, because the right adrenal gland is more cranial, they have described using an intercostal approach instead of a flank approach, but in a similar fashion. So laparoscopic adrenalectomies have been found to, in the right hands, actually end up being shorter in duration than an open approach. So something like 80 minutes versus 108 minutes. We use a 4-port technique. The dog is placed in lateral recumbency. And so the advantage with this, especially with the adrenocortical tumors, is that we have very small incisions. And so if that muscle is weak, there's less chance of it falling apart, and we'll have less chance of wound healing complications if our incisions are small due to excess cortisol versus making just a midline approach. So they did note in some of the studies I was reading, one of my mentors from Michigan State wrote a case series of these when she was at UC Davis, and they do mention that there's possible tumor capsule rupture when you're taking these out, and then you can potentially seed the abdomen, which, I mean, no one wants. So let's see. Yeah. In Dr. Pitt's study, so here, 9 out of 10 dogs, they were able to remove the adrenal gland without a need for conversion. They only converted for 1 case. So pretty good. In terms of vascular invasion, or what we call a tumor thrombus, these have been associated with adrenocortical tumors, so adenocarcinoma or adenoma, but it is more likely to be present with a pheochromocytoma. It's more likely to be found in the right adrenal gland versus the left. It can happen in a multitude of vessels. So I mentioned that the adrenal glands have a highly vascularized supply. And so the vena cava and the phrenico-abdominal vein and then the renal vein are probably your top 3. You can have invasion, transmural invasion into the aorta. Any of the invasion can be transmural or intraluminal. And so those are subtleties that we would like to pick up on CT before we go into the dog's abdomen, so that we can know, okay, can we do a venotomy versus a venectomy? Regardless, if we're going into one of these vessels, it does carry a high risk of hemorrhage. And so we have to be very mindful of that. On top of that, we know that these are more likely to be pheochromocytomas. And so any excessive manipulation of that tumor thrombus can potentially destabilize our patients even more. So in this picture, I don't know if y'all can see it. There's a thrombus invading through the left renal vein up into the cava right there. And so you can see it was really long. Intra-abdominal cooling techniques have been described for venotomies and venectomies to help decrease tissue metabolic demand. It can potentially also help with reperfusion injury. I'd never heard of that, but sounds like a cool idea. Prognosis with these historically has been very scary in the perioperative period. So 12 to 60% for adrenocortical tumors, and then anywhere from 10 to 50% with pheochromocytomas. In 2011, Massari did a retrospective case study for 52 dogs undergoing adrenalectomy for a primary tumor. And they found that if it was adenocarcinoma, the tumor was greater than 5 centimeters in size, or there was a thrombus or metastatic lesions, you had a decreased survival time. Non-functional tumors tended to do a lot better. You still can see similar signs in terms of thromboembolic disease and blood pressure issues because we are manipulating the adrenal glands. There have been more recent studies that show more promising data. Barrera showed that they had 86 dogs, 14 had adenomas, 45 were adrenocortical carcinoma, and then 27 were PHIOs. So risk factors for short-term survival, so death within 14 days following surgery. If you had caval invasion, how extensive that invasion was, if it was a PHIO, if you required an intra-op transfusion, and then post-operative factors including DIC, pancreatitis, hypotension, hypoxemia, and renal failure. All of those were associated with a poor outcome. This paper did not find any increased survival rate with heparinization or phenoxybenzamine administration. In terms of long-term survival, these dogs actually did really well. So if they lived, more than 2 weeks, you're looking at a 4-year median survival time for adenocarcinoma, and the pheochromocytoma patients actually didn't reach an endpoint. They lost some to follow-up, but overall, these patients tended to do pretty well. Mayhew et al., this was a huge study that looked at perioperative morbidity and mortality in dogs with invasive adrenal neoplasm. So looking at, okay, we know that there's a tumor or a tumor thrombus, but how invasive is it? So is it just going into, say, the phrenico-abdominal vein or the renal vein versus is it prehepatic, intrahepatic, or all the way up through the diaphragm? And so the thrombi that were extending through the diaphragm had the worst prognosis for long-term survival. Interestingly, not in the peri-op period. So the majority of these cases, 36 out of 45, were pheochromocytoma, and that's consistent with the data that we've had earlier, where PHIOs tend to be more likely to have these thrombi. They did note a 25% perioperative death and euthanasia rate, which is pretty scary. 3 out of the 4 dogs that died, they weren't euthanized, but 3 out of the 4 dogs that died after this actually arrested intra-op, and then they got back, and then they re-arrested once they recovered. So, yeah, these dogs were pretty sick. In terms of the compiled data from VSSO, they're still showing a 20 to 45 peri-op mortality rate with adrenocortical tumors. These tumors do have a fairly decent local recurrence rate and anywhere from a 15 to 50% metastatic rate. So if you have a unilateral adrenal tumor that's functional, 70 to 90% of these dogs did show clinical resolution. And so that's great. For adrenocortical carcinomas, they did have a pretty good survival rate, especially if they could survive the immediate perioperative time. And then adenomas tend to do really well. In terms of pheochromocytoma, these have a shorter median survival time just because they tend to be more locally aggressive. They don't have as high of a metastatic rate, so 11 to 24%, but they do have a higher chance of coming back and invading other tissues surrounding it. So that can make surgery a lot more difficult. It's not uncommon with adrenal tumors that you'll also have to do a concurrent ipsilateral nephrectomy just because the tumor is so locally invasive. So summary, we have a really varied presentation of how these dogs show up. the main thing to determine is there actually a tumor there? And if there is it functional versus non-functional? It is very important to have everything in line in terms of perioperative management with these patients. So if you can get anesthesia involved, if you can get critical care involved, if you can get cardio involved, that seems to help things out, just because these dogs can fluctuate minute to minute. We still have differing opinions regarding anticoagulants and also phenoxybenzamine administration. I don't think administering phenoxybenzamine hurts. Anticoagulants, it would be nice if we could have a bigger prospective study that would look at this. But things tend to be, overall survival rate and diagnostics tend to be moving in a positive direction. So hopefully we can help these patients out moving forward.